Next, it's my distinct pleasure to introduce our next speaker, which is Dr. Rick Gardner. I actually was introduced to Rick through Norgrove. Thank you, Norgrove. And we actually met recently at the ePOSNA meeting, and I found Rick to be very intelligent and insightful and young, but very experienced. So he recently, I think Rick grew up in England and then is currently attending surgeon at Hospital for Sick Kids in Toronto, Canada, but spent a good part of his postgraduate years in Africa, sub-Saharan Africa, as a chief medical officer for Cure International, which is an NGO, and has spent a fair amount of time in 3 different countries in Africa: Malawi, Ethiopia, and Zimbabwe. And he's also the chief examiner for the College of Surgeons in East, Central, and South of Africa for pediatric orthopedics. So Rick's going to talk to us about teaching and training in austere environments. Rick, please take it away.
Sanjeeva, thank you very much indeed. And yeah, thank you so much for the opportunity to talk with you all today. So I've got no disclosures other than I'm not a professional limb reconstruction surgeon. So I'll be talking more about the broader aspects of pediatric orthopedic training. And actually, Norgrove and I, we spent a long time together, and we have many views in similar, and maybe some of my views are more on the subspecialty side. So hopefully a good juxtaposition. I spent 11 years living and working in sub-Saharan Africa, in Malawi, Ethiopia, and Zimbabwe with Cure. It's an NGO, which is a network of 8 hospitals. 7 of them are in Africa, and all of which focus on pediatric reconstructive surgery. And in this time, I work closely with colleagues in government hospitals and also operating within those hospitals, sometimes for several months as part of an initial relationship period. And this talk on teaching and training on austere environments and the related barriers and opportunities is with both places in mind: the government hospital system and also in an NGO hospital that is aligned with the broader healthcare service of the country. I'll also talk about maximize the impact of mission trips and the need and potential for fellowship training. I'd just like to really recognize the enormous impact UCSF has and continues to have around the world through the pioneering of work of Dr. Coughlin, Dr. Goslin. The IGOT platform and the Smart Course are exceptional. I had the great privilege back in 2004 to be working alongside UCSF orthopedic residents in Umtata, South Africa. And I've been very inspired by all of Colin Sabatini's work in Uganda as well. So much excellent work has come from surgical mission trips, However, undertaking high quality patient care in less resource environments can be a great challenge. The local team may be unfamiliar, the pathology is often complex and late presenting, and the availability of equipment and implants is often limited. And to help manage some of these issues, some organizations will travel with a large team of surgeons and anesthesia providers and nurses. And they may travel with these specialist implants and equipment, and they can do a large number of surgeries over the course of the week. But there are a number of issues with this, and at times the focus on surgical numbers has meant that local teams have been displaced by the international surgeons and the anesthesia providers and the visiting trainees, and the visiting surgeons might be managing cases that are outside of their normal comfort zone. New stress can be placed on the local OR team, and local supplies and at times follow-up can be an issue in management of any complications. And furthermore, there can be little transference of skills. I think many of us are a big believer in the benefit of regular, annual if possible, visits by a subspecialist with a training mindset, with one really of transference of skills and not so much of surgical volume. So the visiting surgeon is a skill set that is needed in the local host institution. The patients are carefully screened ahead of time, and maybe the 1 or 2 surgeon team means they can work alongside local providers with intentional transfers of skills. And it's a big shift away from the high-volume surgical camp model, but it's one that is increasingly adopted. And by way of example, when I spent time in Ethiopia, it was a great beneficiary of annual visits from Dr. Scott Cozen and Dr. Duretti Fufa, upper limb surgeons. We had huge numbers of surgeons presenting with obstetric brachial plexus palsy, lacking shoulder abduction and external rotation. You couldn't bring their hand to their mouth. Children with Volkmann's ischemic contractures that had developed following splintage by traditional healers, and radial club hand needing wrist reconstruction and policization. And over 7 years of annual visits by Duretti and Scott, Ethiopian surgeons are now performing high-quality tendon transfers for brachial plexus palsy, flexor slides for vulvar ischemic contracture, and polycizations and other procedures that have never been performed in the country just through an annual weekly trip. And many other surgeons organizations are focusing on a similar model. Of course, such knowledge transfer needs a local champion to gather appropriate cases and clear-eyed discussions for what is needed at the local context, but it's a huge win. I just wanted to touch on implants as well. If you're making regular trips and you're taking care of patients with late presenting trauma or those that need deformity correction, I would consider reaching out to some of the Indian suppliers rather than bringing in Western implants. In many ways, it is preferable because they're accessible by local hospitals within Africa and beyond. The cost is low and achievable for the patients in the majority of setting, and the quality and the metallurgy is now generally excellent. Zirkel and sign was mentioned by Norgrove. Just what a transforming aspect he's had on the world. And of course, the reuse of circular frames that we will use. But in many ways, it's worth checking out what the Indian suppliers can do, because actually it can be a localized, sustainable solution for many of the places you might choose to visit. Courses are a wonderful way of collaborating with the international and regional faculty. The clinical case discussion with participants bringing their own cases, cadaveric dissection and sawbone workshops are a huge win and often expand the horizons of participants about what is possible. And I just want to highlight a course last month in Zambia. There was a collaboration between POSNA members, those from the British Children's Orthopaedic Society and regional African surgeons, who came to teach 32 participants from 5 regional countries. Now, this will be an annual event moving forward, and maybe some of you on this call might be interested in being trainers as well. Dedicated limb reconstruction courses are in huge demand across Africa, and they can often be a springboard to developing local expertise and long-term international collaboration, as they have been in both Ethiopia and Uganda. And I'd just like to spend the last few minutes on fellowship training. We've had some great discussions on this already, and I think it's important to stress that in many low and middle income countries, subspecialty training is strongly desired by surgeons in the government sector and by the hospital leadership. 20 years ago, the main focus in sub-Saharan Africa was to have enough surgeons to cope with the volume of trauma and infective pathology. But now the number of surgeons accredited locally through organizations like COSEXA, the College of Surgeons of East, Central and Southern Africa, and the West African College of Surgeons, mean that there is a sufficient number of surgeons in government hospitals to allow for subspecialization. But of course, where should this be done? Now, establishing a fellowship program in a government hospital or an NGO has a great benefit of local context regarding pathology, equipment, and implants, but may be harder to establish and need a training the trainers model. International fellowships have been well established, but carry issues regarding local licensure and a very different context. Now, Colleen Sabatini will shortly talk about her excellent fellowship program in Uganda. Mark Barry has also been instrumental in creating a pediatric orthopedic fellowship in Tanzania, also using international specialists that spend a month at a time at these centers to train local surgeons. And the Cure hospitals in Kenya and Ethiopia have been running an annual fellowship program for many years with their fellowship-trained local faculty. One key part is the graduating fellows within the sub-Saharan African region then sit the annual pediatric orthopedic examination with COSEXA. And it's essential because it gives them the recognition that they need to establish themselves in their home country. COSEXA is a fabulous organization overseeing the accreditation for 14 regional countries, and the annual conference and exams in December are in a truly excellent way of getting involved of training within the region. Regarding international fellowships, there are many benefits that we've discussed on the clinical, academic, and collaborative front, but some potential issues include a different patient population or pathology and an environment that has more resources. And by way of example, Dr. Sami Halu, a talented graduate from the orthopedic program at Addis Ababa University, spent his fellowship year learning pelvic and acetabular reconstruction and arthroplasty in Toronto a decade ago. Now, prior to this, all acetabular fractures were managed non-operatively in Ethiopia, all the way through. And on return, Dr. Sami changed this, demonstrating exceptional results even without C-arm, with a new generation of residents and now fellows receiving exceptional training from him. The academic skills learned while in Canada was essential, as was the horizon expanding perspective that is gained in a specialist centre. So to echo earlier discussions, a blended model might just be ideal. And in this, the first year can be spent in the National Specialist Unit, with a second year undertaking a period in the International Centre, ideally being licensed to operate. And the benefits of each would be gained, and the surgeon well placed academically and clinically to handle complex local pathology. The international collaboration gain can continue to bear fruit over a career and lifelong relationships formed. And as Chris and Scott and Sanjeev said earlier, it is a true privilege to be part of such training programs overseas. So thank you very much for your time. There are many ways to be involved in training overseas, and I'll be delighted to connect anyone who may be interested.